Hey everyone, and welcome. Today, we're jumping into a really important topic, one that's incredibly common and honestly pretty stressful: bleeding in the first half of pregnancy. For any clinician, this is one of those situations where having a sharp, clear game plan is absolutely critical. So let's get right into it. First, let's start with a number that really tells you why this matters: 20 to 25%. That's the percentage of all recognized pregnancies that will have some kind of bleeding. So you're not just going to see this once in a while, you are going to see this all the time. So what are we officially talking about? We're talking about any bleeding from the genital tract that happens before 20 weeks. And look, even though it's common, the stakes are really high. We know that about half of these cases, sadly, will end in a miscarriage. And that's exactly why we need to have our approach down cold. Okay, so when a patient presents with bleeding, your brain has to immediately ask one huge critical question. Is this normal, or is this a sign that something is seriously wrong? Is it physiologic or pathologic? Because the answer to that question changes everything you do next. This is how we start to figure that out. On one hand, you have physiological bleeding. Think of it like implantation bleeding. It's usually just some mild spotting, there's really no pain, and it goes away on its own. But pathological bleeding, that's a totally different beast. You're looking for red flags, right? Bleeding that's getting heavier, not lighter. Real uterine cramping. Maybe the patient has even passed some tissue. And a huge one: any sign of hemodynamic instability. Are they dizzy? Do they feel like they're going to faint? The big takeaway here is that pain and the amount of blood are your first major clues that you're heading down a dangerous path. So once you suspect the bleeding is pathological, your mental map has to zero in on the big pregnancy-related causes. And when it comes to early pregnancy, there are three main diagnoses that have to be at the top of your list. And here they are, the big three. First, abortion, which is by far the most common. Second, ectopic pregnancy, which is the most dangerous. And third, hydatidiform mole. You know, just remembering them with these little tags, most common, most dangerous, is a really powerful way to prioritize your thinking, especially when you're under pressure. So let's quickly define these. First up, abortion. The official definition is the end of a pregnancy before 20 weeks, or if a fetus is expelled weighing less than 500 grams. Since this is the most frequent cause, statistically, it's the diagnosis you're going to run into the most. Next up, ectopic pregnancy. This is when the embryo implants somewhere outside the uterus, and 9 times out of 10, that's in the fallopian tube. The reason we call this most dangerous is because of the terrifying risk of rupture. If that tube bursts, it can cause a massive, life-threatening internal hemorrhage. This is a true surgical emergency. And our third one is the hydatidiform mole, which you might also hear called a molar pregnancy. This isn't a problem with the fetus itself, but with the placenta. Basically, the tissue that's supposed to form the placenta grows abnormally, and it's this abnormal tissue that causes all the problems, including the bleeding. Okay, so we've got our three main suspects. Now for the million-dollar question. How in the world do you tell them apart? Well, this is where good clinical work comes in. It's about using a toolkit of signs, symptoms, and tests to put the puzzle together. Let's break down the framework that helps us do just that. This table right here, this is the whole game. It's the mental checklist you need to run through. You start to see patterns, right? With an abortion, pain can be all over the place. The cervix might be open or closed, and the HCG hormone levels are usually what you'd expect, or maybe they're starting to drop. Now look at ectopic pregnancy. The pain is usually severe, the cervix is closed, the uterus feels smaller than it should, and this is key: the HCG levels are rising but way too slowly. Then you have the molar pregnancy, with its classic signs: a uterus that's actually bigger than expected, ridiculously high HCG levels, and that classic snowstorm look on an ultrasound. Each one has its own clinical signature. Okay, let's put it to the test. Quick scenario: a patient comes in with severe one-sided belly pain, and then she faints. Right there. Based on what we just saw, what diagnosis shoots to the absolute top of your list? Ectopic rupture, 100%. That combination of severe pain and then fainting, what we call syncope, is the textbook red alert presentation for a ruptured ectopic pregnancy. It's the diagnosis you absolutely cannot afford to miss. All right, let's do one more. This time, your patient says she cannot stop throwing up. When you do an exam, her uterus feels way bigger than it should for how many weeks pregnant she is. And then the lab calls. Her HCG levels are through the roof. What are you thinking now? Molar pregnancy. It has to be. That unique triad of symptoms, the crazy vomiting, a uterus that's too big, and sky-high HCG levels, is screaming hydatidiform mole. In fact, it's those super high HCG levels that are actually causing all that nausea and vomiting. So why do we hammer this framework home? Why is being this systematic so important? Well, because getting to the right diagnosis and getting there fast isn't just about being a good student. It's about keeping your patient safe, period. And you don't have to take my word for it. This quote really says it all. Bleeding is not just a symptom to manage, it's a critical warning sign. And if we delay or get the diagnosis wrong, it can lead to devastating complications for the mother. And here's just a snapshot of what we're trying to prevent. We're talking about massive blood loss leading to shock. We're talking about overwhelming infections, future infertility, a bizarre clotting problem called DIC, and yes, in the worst case scenarios, even death. This is why having a system isn't just good medicine, it's life-saving medicine. So I'll leave you with this final thought. You've done your history, you've done the exam, you've looked at the labs, you've used this framework, and you have a really strong suspicion about what's going on. What is the single most important tool you're going to use next to actually see what's happening and confirm it? Because that ability to look inside is what turns a good guess into a certain diagnosis. Thanks for tuning in.